Hey everyone, this is your recorded lecture for Wednesday. What's the date? Wednesday? Anyway, this coming Wednesday, the day before Thanksgiving. And then Monday we come back for a lecture in class, and the following Wednesday lecture in class, and then 2 weeks from today, which is Monday, you have your last exam. So I'll get started. I'll do a little bit of this lecture, and if you have any questions, please email me over the weekend. And I do a brief A&P review of lung function just to kind of refresh your memory. And as I've said with every unit up till now, just make sure you refer to your books and your previous A&P notes for further clarification to help you understand. But as far as our brief overview, we of course know that the primary function of the lungs is gas exchange. So we know, you would think of it normally without, thinking about physiologic function. We know we have to breathe, but the whole purpose of breathing is to get oxygen into the body to our tissues. And we talked a bit about that exchange when we talked about the circulatory system. And then, of course, to remove waste from the body, we breathe waste out, the main one, of course, being carbon dioxide, but also other metabolic waste. And, of course, we use the physiologic or the anatomic structures of the lungs, the airways, the chest wall, and the pulmonary circulation in order to achieve gas exchange. So, that being said, we know that the lungs interact with the central nervous system. So the function of the lungs goes with those anatomical structures that I just mentioned, but we of course need some kind of other control over the pulmonary system, which comes in the form of the central nervous system, to help innervate all of those structures we talked about. I don't think I mentioned the diaphragm, but the diaphragm is included, as well as, again, the chest walls, muscles, the circulatory system, and the airways. Of course, our secondary function we've talked briefly about is that the respiratory system works in concert with the renal system for acid-base balance. So we can use gases to regulate acid-base balance, such as oxygen and carbon dioxide, and the kidneys can excrete and reabsorb hydrogen ions to regulate acid-base balance. So as far as I keep saying physiologic, but it's the anatomic structures that help us to regulate our pulmonary system. We can start right up at the upper airway. So let me just get the cursor out here. So the upper airway at the nose, the throat, the pharynx, the oropharynx, and we know this area will warm and humidify air as we breathe it in to the body. So we know if you think about going out on a really, really cold, dry day, and breathing in a deep breath of air, and you can feel that that kind of shocks your respiratory system. If we didn't have the ability to warm and humidify air, that's how it would feel all the time when we breathe. So that's why it's important to have the purpose of this oropharynx in order to do those two things, but also to filter foreign bodies, things that we don't want to breathe into our lungs, and pathogens up in the upper airway. Then we have our larynx, which is a little bit lower. Our larynx connects the upper and lower airways and contains also your vocal cords. And then we get into our other airways, our lower airways, which start at the trachea. So remembering the trachea is at the back of the throat, right next to the esophagus. So the trachea is that tube that brings air in and out of the lungs, that main tube. So the trachea in the middle, which branches at the carina here at the bottom, and it branches, of course, into the right and left lung. And we know that the two main bronchi will also continue to branch and branch and branch into our bronchioles and finally to the alveoli at the very lower ends of our airways. So many, many branches. Within these airways, we have different types of cells. We have our goblet and ciliated cells. Of course, our goblet cells are important for secreting mucus, and which is a protective coat within the lungs. The ciliated cells are in constant motion. We talked a bit about ciliated cells when we talked about tissue adaptation. So the cilia primarily help to sweep the airways, so to sweep pathogens and debris up and out of the airways. As we branch lower from the bronchioles, we get into the alveolar ducts and the alveoli, as I said, which together are called the acinus, A-C-I-N-U-S. So that again is the alveolar ducts and the alveoli. And here's where we see our gas exchange. So our main area of gas exchange again is in the alveolar ducts. And within the alveoli we have two major types of cells. Type 1 alveolar cells, which are mainly for your gas exchange, and your type 2 alveolar cells, which secrete surfactant, which help to lower surface tension, which in essence will help the alveoli to expand. Just to get a little bit more detailed into the lobes of the lung, we know on the right we have 3 lobes, and on the left only 2 lobes. We know that the right middle lobe, where is it here? So the right middle lobe, the bronchus is a little bit shorter and smaller. So if you're going to get a problem, we often see it in the right middle lobe. And we also can see atelectasis, which is lung collapse, and infection in any of these areas. As far as what is gas exchange, where is it taking place, we already said that gas exchange primarily takes place in the alveoli. So if you look here, if you remember from anatomy, you know the alveoli look like clusters of grapes, and you have to remember that those little clusters of grapes are very much coated or covered by the capillary beds of the circulatory system. So with these capillary beds wrapped around the alveoli, we know we have arterial and venous circulation. So the venous circulation is dropping off carbon dioxide into the alveoli, so that gas will cross over several layers of tissue to get into the airways, where oxygen is being absorbed through these layers of tissue from the airway to bring oxygen into the blood. So again, that's in essence gas exchange taking place, getting rid of the carbon dioxide and bringing oxygen in. And of course we know that that oxygen flow and getting that oxygen into the circulation is very important to not only bring oxygen to our tissues, but to provide nutrients to our tissues and to overall upkeep the human body. So to explain that a little bit further in words, now that I showed you the picture, as we said, this pulmonary circulation, which I just showed you, all those lovely little blood vessels, facilitate gas exchange. As I said, we are sending both oxygen and carbon dioxide through layers of tissue back and forth between the blood vessels and the alveoli. Not only does this provide nutrients to the lung tissues and oxygen to our body's tissues, but it will also help to filter any debris and clots. What I showed you is a network of capillaries and veins around the acinus, remembering that the acinus includes the alveolar ducts and the alveoli, and these gases again cross over the alveolo-capillary membrane, which are the layers of tissue between the alveoli and the capillaries. We also have a lymph system in the lungs that, like we said earlier in the year, will carry any excess fluid away from the tissue. Now we have to think about, when we think about gas exchange, we also have to think about how many layers of tissue the gases have to go through. So we're going inner to outer here. We're starting inside the alveoli and going into the bloodstream to the red blood cell, which again, of course we know is going to carry the oxygen to the body's tissues. So think of yourself taking in a deep breath. The surfactant helps your alveoli to expand as the air comes into them, but the gases have to cross over that surfactant as well, because remember the surfactant coats the inner alveoli. So the gas will have to cross through the surfactant, which is fine, then through the alveolar membrane. Now this is fine too under normal circumstances, but we start to think of, since we're in a patho class, we start to think of, well, what if there's a problem with the alveoli? Then we can start to see changes in gas exchange. But for right now, we'll just talk about normal. So the oxygen goes through the surfactant, then it has to go through the alveolar membrane, and then it has to go through interstitial fluid. So we know that between all of our cells we have a little bit of fluid, and that's okay too. The gases can get through that interstitial fluid, but then we have to start to think again about patho. If there's extra fluid there, then that's going to make it more difficult for gas to get to the blood vessels. So once it gets through that fluid, it gets to the capillary membrane, which I showed you is wrapped around the alveoli, passes through the capillary membrane into the plasma, and then has to find the red blood cell to attach to the hemoglobin, and then the red blood cell will carry it to the body's tissues. So a visual showing you again the alveoli. So again, air comes into the alveoli. We have surfactant inside the alveoli, then the alveolar membrane, the interstitial space, which may have extra fluid. If there's extra fluid in there, these membranes will move further apart, and it will be more difficult for gas to get into the blood vessel, and vice versa for carbon dioxide to get out. Then the oxygen gets in and attaches to the red blood cell and is circulated. So this is just showing you, I've explained only oxygen to you, but you also have to remember that carbon dioxide must come in the opposite direction, from the blood to the alveoli for excretion. So that's all good, and that works well. When everything's working properly, we get good gas exchange. But for it to work properly, we of course need our pulmonary functions to be intact. So let's talk a little bit about pulmonary functions. Ventilation. Ventilation means air movement in and out of the airways. So our respiratory rate will reflect our ventilatory rate. So ventilation is not the same as respiration. However, again, respiratory rate will reflect how many times we're ventilating in a minute, for example. Ventilation depends on the pressure variance. So it basically is saying to us we have to decrease pressure in order to allow air in. So pressure variance goes like this. When you're ready to take a deep breath in and you're kind of relaxed without taking that breath, we know there's no stimulus for air to flow in. But if we make more room in the lungs, then it will probably pull air in because there'll be more space for it. So our muscles in our chest wall and our diaphragm will pull the chest wall open so that air will flow into the lungs. Once the air is in, we take a breath in, then we relax those muscles and air will flow passively out. By relaxing the muscles, we'll diminish the size of the lung fields, put pressure on the lungs, and essentially force air out of the lungs. So the pressure in the chest will increase and air will come out. We also think about resistance within the actual airways. So resistance in the bronchi, the bronchioles, and the alveoli. If there's a lot of resistance in the airways because maybe the airways are smaller for whatever reason, they're spasmed or they're inflamed, then there'll be higher resistance in the airways and it'll be more difficult to ventilate. And then lastly, we think about compliance of the lungs. Compliance refers to the stretchiness and recoil of the lungs. Again, going back to our rubber band example, like we talked about in the heart, we want the lungs to be compliant. We want them to be able to stretch, but we also want them to recoil so that we don't keep air in the lungs that doesn't belong there. Pulmonary function also depends on pulmonary perfusion. How is blood flow through the pulmonary circulation? Are there any issues with circulation? Is there a clot in there? Is there some kind of vascular disorder that we talked about last unit, like pulmonary hypertension, that causes difficulty with pulmonary perfusion? And then diffusion of gases. Oxygen and carbon dioxide exchange at the alveolar capillary membrane depends on the partial pressure of the gases. Is there enough oxygen being breathed? Is there enough oxygen in the air around the person? Is there the carbon dioxide able to cross through the membranes to get out of the body? So partial pressure means that there's more of it on one side than the other. So when we breathe in, the partial pressure of oxygen in the lungs gets very high. So then it's higher in the lungs than it is in the blood, so our body naturally pushes the oxygen into the blood, and vice versa. The venous blood coming back to the heart and into the lungs from the body has a very high concentration or partial pressure of carbon dioxide, so that gets pushed into the lungs for excretion. This is all dependent, again, as I said earlier, on the integrity of the tissue at the alveoli and at the capillary membrane. So to get a little more specific about ventilation, as I said, it is movement of air in and out of the lungs for gas exchange. And as we said, it depends on diffusion, so the gases are moving from greater pressure to lower pressure. So again, when we breathe in, we want the oxygen to go from high pressure in the lungs because we just took a big breath of oxygenated air, and if as the deoxygenated blood flows through the circulation, we expect the body will push the oxygen into the blood because of that greater partial pressure of oxygen in the lungs compared to the blood vessels. So as we inspire air, the lungs increase in size because of decreased pressure, and as we expire, and I explained this earlier, the lungs decrease in size, increase pressure, and push air out. And as we said, ventilation depends also on compliance and airway resistance. So all of this has to go together in order for the person to be able to perform the functions of the pulmonary system. And then don't forget, we also have control with the neural system, which include respiratory centers in the brainstem, in the periphery, and in the lung. We also think about volumes when we talk about lung function. What are normal lung volumes? So how much air fits in the lungs, and then there are different ways to look at the different lung volumes. Tidal volume is the amount of air that's breathed in or out with normal breathing. So if you're sitting there, you're taking normal breaths in and out, you're breathing in and out about 500 cc's of air. So you're, again, at rest, normal tidal volume. Inspiratory reserve volume is the amount of air that you can inspire beyond the tidal volume. So this is when you take a normal breath in, and then you breathe in beyond that. So almost like a gasp or a longer inspiration. It's a purposeful thing. So it goes beyond, again, what you would normally be breathing if you weren't thinking about it. And you can do about 3 liters of inspiratory reserve volume. Expiratory reserve volume is how much you can exhale beyond a normal exhalation. So amount exhaled beyond the tidal volume. And this is normally about 1 liter. Reserve volume is the amount remaining in the lung after forced expiration. So say you went through your expiratory phase, so you breathed out, then you breathed out as much as you possibly could. We always have some air remaining in the lung to prevent complete collapse. So the amount remaining after all of that exhalation is about 1.2 liters or 1200 cc's of air. Vital capacity is the maximal expired air after maximal inspired air. So you take a deep, deep, deep breath in as far as you can, and then you blow it all the way out, all the way till you can't blow out any more air. And that's approximately 4,500 cc's. And then the total lung capacity is the total amount of air that the lung can hold, which is basically all of your volumes together. And then there's dead space that doesn't do much of anything, which is about 150 cc's. All of these lung volumes become important when we're trying to figure out if someone's having some symptoms of an abnormal pulmonary function. We look at the lung volumes through pulmonary function testing to see where there might be an abnormality with, again, lung function. We specifically look at something called forced vital capacity, which is essentially the same thing as vital capacity, but we're measuring it on a machine. So these are your pulmonary function tests, and these are probably your most important as far as trying to figure out what's wrong if somebody's having symptoms. So what we do is we have somebody basically take a full inspiration to total lung capacity and force all the air out, blow out into a machine, and time it. We compare how much air comes out over 1 second to the total amount that comes out, and that's called your FEV1, forced expiratory volume over 1 second. And when you compare the two, you can tell whether someone's trapping air in their lung if it takes too long for the air to come out, If it comes out more quickly than normal, we can see that there's another issue. So it really helps us with diagnosis. It's especially helpful and most often used with obstructive lung disorders such as COPD and asthma. And we'll talk more about this as we get into the specific lung disorders. So the other important pulmonary function test that we use is peak expiratory flow. Again, how quickly is the air coming out, which is important to measure in asthma as well. So again, the main point of this particular slide, and again we'll talk more about pulmonary functions as we get into the particular disorders, is that these are the most commonly used values in trying to diagnose a specific disorder. And this is just a visual showing you all of your pulmonary functions and kind of where they are and how you get them as far as a person's breathing. We also consider the work of breathing a minute volume, which is the amount of effective ventilation over a minute. Depending on the disease state, we're going to see different tidal volumes. So with a restrictive disease, and we'll talk more about this later, we'll have a less volume. With regular person breathing, we have normal tidal volume. With obstructive disease, we have higher tidal volume. So we have to see that to maintain a normal breathing pattern, people with different disease processes will have to alter their respiratory rate. So that's basically your ventilation. We also can think about, and I explained this already, but airway resistance. So this depends on the size of the actual, or the caliber of the actual airway. So if you remember caliber, it's when you look down a tube and how wide that tube is. So if the tube is smaller, there's going to be higher pressure within that tube. So that's the same with breathing. So it will be more difficult for the air to flow through if there's a smaller caliber. If there's a larger caliber, obviously, it will be easier for the air to flow through, but sometimes we can go to too large a caliber where the airway can actually collapse on itself. So there are different ways that airway resistance affect gas exchange and pulmonary mechanics. Pulmonary mechanics, as I said, also depends on the compliance. So remember the stretchiness and the recoil. Compliance is the ease of inflation. It's the stretchiness determined by elastin and collagen in the lung tissue. Elastin will increase the ease of stretch, whereas collagen will resist stretch. So they should be in balance. Those two substances should be in balance for normal pulmonary function. And we'll talk about disease states where they're out of balance and we start to see changes in those, in the recoil, in the compliance of the lung. Elastic recoil is the ability to recoil to the original position that is provided by radial traction. So again, when you stretch it out, it means it can bounce back. And we do run into, as I said, disease states where we lose our recoil. This shows you a few different situations where we have, again, our elastic and collagen fibers. We're showing an increased airway resistance here with the decreased caliber of the airway. There's a foreign body in this airway, so showing you increased airway resistance. And this is showing you damage to the elastic fibers, so we would be looking at a problem with compliance in this particular situation. We also have to talk about perfusion or blood flow. We talk about as I explained earlier, we have both ventilation and perfusion going on at the same time, which is usually matched in that 4 liters of air are inhaled per 5 liters of blood that flow through the lungs. So when they're in balance, 4 to 5, we have a ventilation perfusion ratio of about 0.8%. I'm sorry, of 0.8, not percent, 0.8. So that's normal. We can see this mismatching take place when there's either a problem with the breathing or ventilation, or if there's a problem with the blood flow. And we can tell which is the problem depending on this ventilation perfusion ratio. So when we go to normal, as I said, normal ventilation, V is ventilation, Q is for perfusion, and I'm not quite sure why it's Q, but it's a commonly accepted abbreviation per perfusion. So we look at VQ, and that means that ventilation is normal. So we have about 4 liters of air to 5 liters of blood. If there's a problem with air flow, we'll see a decrease in that 4 liters. We'll see a decrease in the first number. So maybe we have 2 for for airflow, and still 5 normal pulmonary circulation flow. So if that's the case, then we have a low VQ. Okay, so that would be 0.4. All right, so that means there's a problem with ventilation if it's low, because again, this first number decreases. If ventilation's okay, so these alveoli are ventilating properly, but there's an issue with circulation, so you can see there's a clot over here, then we'll still get our 4 liters of airflow, but we'll get a decreased amount of blood flow. So say maybe we have 4 liters of oxygen or air to 2 liters of blood in a time period. That will make the VQ high, so the ventilation perfusion mismatch will be high. Okay, so make sure you understand that depending again on the area that's being affected, whether it's ventilation or the blood flow, you're going to see changes in the ventilation perfusion ratio, and you should understand which change goes with which disorder. Diffusion we talked about already, so again, wherever the higher amount of gas is, it will diffuse into the area of lower gas. So that's simple chemistry. Then we'll talk about areas when the alveolar capillary membrane is altered so that diffusion cannot take place adequately. We also want to talk about the oxygen actually getting to the tissues. So we talked a bit about gas exchange from the lungs to the blood, but then there can sometimes be a problem with the oxygen actually getting to the tissues after it's already in the blood. And that has to do with the attraction of the oxygen to the red blood cells, or the hemoglobin. And different disorders can change that attraction. So, normal oxyhemoglobin dissociation means that the oxygen gets into the blood, attaches to the red blood cell, and it gets to the tissues. And once it gets to the tissues, the oxygen is released into the tissues. So that's normal. Sometimes with certain respiratory and other disorders, and we'll focus on the alkalosis and acidosis because that's the ones we're going to talk about most commonly in this unit, sometimes the oxygen will get into the blood, it'll get onto the hemoglobin, but then once it gets to the tissue, the red blood cell doesn't release it to the tissue because it's too attracted to each other. Okay, so the oxygen is stuck on the hemoglobin. So you have plenty of it in the blood, but it's not getting to the tissue, so you actually get tissue hypoxia. That's called increased affinity. It's called a left shift in the dissociation curve. And things like alkalosis, decreased carbon dioxide levels, decreased temperature, carbon monoxide poisoning can cause increased affinity. So you get tissue hypoxia because the oxygen can't be released from the red blood cells. And then other times you have the oxygen get into the blood, but it doesn't get onto the hemoglobin. So it's released too early, so it doesn't get to the tissues. So the same thing, you'll have tissue hypoxia, but for a different reason, because the oxygen can't stay attached to the red blood cells. So things like acidosis, low oxygen, high PCO2 or CO2 levels, hyperthermia, and these all cause a right shift. Again, same result. The oxygen isn't getting to the tissues and you get tissue hypoxia, but for different reasons. To figure out if something is going on, we can use with gas exchange, ventilation, etc., we can use what's called an arterial blood gas. Now I talked a bit about this semester, And I told you that this is a special kind of blood test that has to be taken from an artery, and we can look at a reflection of our pulmonary function based on our blood gases. So remembering again, we said earlier that the respiratory system is responsible for acid-base balance along with the kidneys, and it will reflect in our pH level, which reflects our acid-base balance. Our blood pH should be between 7.35 and 7.45, and changes in oxygen and carbon dioxide will change our pH. Our CO2 levels in the body should be between 35 and 45. Our HCO3, which is our base, helps to neutralize acid, should be between 22 and 26. And our PO2, or oxygen level, should be between 70 and 100. And our saturation, which is a little different, so PO2 is from the blood. Oxygen saturation can be taken both from the blood sample and from the little probe on the finger, should be between 97 and 100. Again, if gas levels change in the body, we can see changes in arterial blood gases. So for now, I'm going to have you guys know the normals, and we'll talk a little bit about changes in those values that occur with different disease processes. And then next semester, you'll start actually interpreting blood gases in, I believe it's in 250. So, and then junior year, you'll continue that. So you'll be kind of an expert once you graduate, or by the time you graduate. All right, I mentioned earlier that the neurologic system also plays a part in controlling our respiratory function. We have several, again, respiratory centers. We have a CNS respiratory center in the medulla of the brain, which is in the brain stem. Chemoreceptors all over the body that detect pH, PCO2 and PaO2, and therefore, based on those results, will regulate the rate and depth of breathing. Baroreceptors, which sense pressure in the blood vessels, which can help increase our respiratory rate if more oxygen is needed, and also will increase blood pressure. And proprioceptors, which detect motion. So increased motion may need increased oxygen levels, etc. So that's your basic overview of pulmonary function. So hopefully that made sense to you and was mostly review. Now we're going to get into some of our general alterations in pulmonary function. So these can be applied to many, if not all, of the disorders we'll talk about in the pulmonary unit. So we'll talk first about hyperventilation, because you don't see it as much as hypoventilation, but we do want to make sure that we know about it because it can cause changes in our blood gases and cause problems all over the body. So hyperventilation means that alveolar ventilation, or breathing, exceeds the metabolic needs. So your body's breathing too fast, more so than it needs for oxygen levels and for carbon dioxide levels. So therefore, as we do this with the increased respiratory rate, we start to drive the PCO2, or carbon dioxide levels, down too low. So remember, PCO2 is 35 to 45, so we start to see PCO2 levels drop below 35 because we're breathing too much of it out, because we're breathing too fast for what the body needs. Remember, metabolic demands mean that it's basically the cell's demand for oxygen in order to make energy. Okay, and then as the cells make energy, they create waste, which includes carbon dioxide, which we need to get rid of. So we're outpacing the body's needs. Some of the reasons for hyperventilation include fever, pain, anxiety, brain neurologic head injury, pulmonary diseases, and sepsis. Sorry, let me go back for a second. So with this, it's pretty easily fixable. We would want to basically slow down the respiratory rate, but if we let it go on, it could cause the pH levels to get too high, and the person could become alkalotic. So we do want to fix the issue, the underlying problem, as soon as we can. Hypoventilation is by far more common. You see it much more often, and what we're having here is we're not having enough alveolar ventilation to meet the body's demands. So without enough ventilation, we're not getting enough oxygen into the blood, not getting enough carbon dioxide out of the blood, whether it's because of a lower respiratory rate and depth, often secondary to some kind of health problem or disease. It results in hypercapnia, and hypercapnia is high carbon dioxide levels, so high is being over 45, and hypoxemia, or low oxygen levels, which are below normal is below 70, but especially below 60 is where we start to get into the real danger zone. And what happens with a high CO2 and a low O2 is we get acid buildup in the blood, so we start to see acidosis, and pH levels get low. So we have a couple of things going on here. As I said, we have hypercapnia, which is high CO2. Some of the symptoms of hypercapnia include vasodilation, so lower blood pressure, flushing, headache, tachypnea or increased respiratory rate, disorientation, sedation, and coma. So this is quite dangerous. We know that hypoxemia is reduced oxygen in the blood, and hypoxia is decreased tissue oxygenation, which is a problem that hypoxemia leads to. And we know without oxygen, our tissues can't make energy, and they start to dysfunction. So our symptoms of hypoventilation often connect to that lack of oxygen. Now, if it's a low threshold or a low level hypoxemia over a long period of time, we could see compensation like increased red blood cells, increased production of red blood cells to try to grab more oxygen that's available. However, in the short term, we see things like tachycardia, vasoconstriction initially, but since it often coexists with hypercapnia, we will often see vasodilation or lowering blood pressure, cyanosis or bluish discoloration of the skin, especially late in hypoventilation, restlessness, agitation, combativeness, delirium, stupor, and coma. Now, don't forget I told you guys, endocrine unit. When someone has a sudden change in mental status, the two first things that I check are, of course, oxygen, so airway, breathing, circulation, and blood sugar, because those are the two, in practice, the two main reasons I've seen for sudden change in behavior are those two things, low oxygen and low blood sugar. If we don't intervene with hypoventilation, hypoxemia, hypercapnia, we can end up in a situation of acute respiratory failure. Acute respiratory failure, if I could just jump down for a second, gets to the point, or is diagnosed when we get to the point where the PaO2 has now diminished to less than 50 and the PCO2 has climbed to over 50, with a pH, a very low pH of less than 7.25, or severe acidosis. And as I said, this is in a situation where we have severe hypoxemia and often severe hypercapnia, usually related to a ventilation-perfusion mismatch. So some reasons for acute respiratory failure include primary lung disease, so things that we'll talk about in the unit, such as cancer, lung cancer, COPD, asthma, tuberculosis, pneumonia. So all the things we'll talk about from here on can cause acute respiratory failure. Obesity, especially Pickwickian syndrome, which basically means that there's an increased demand of the tissue for oxygen because basically there's too much tissue. And all that tissue needs energy, so it will demand more oxygen. Pulmonary embolism, or PE, interferes with circulation to the lungs. Pulmonary edema, or heart failure, remember that will increase interstitial fluid and decrease gas exchange. Central nervous system disorders, such as brain damage, any damage to the respiratory centers. Neuromuscular diseases like MS, ALS, where there's disruption in the signals between the brain and the body's tissues. Trauma in postoperative patients, because for several reasons. Post-op patients are very sedated, they've been under anesthesia, they're unable to take deep breaths, they may not be aware of their diminished breathing, Anesthesia does depress the central nervous system, including the respiratory center, and often postoperative patients are given pain medicines that will diminish the respiratory function as well. So acute respiratory failure essentially has the same symptoms as hypoxemia and hypercapnia because it's pretty much, the same clinical situation with just lower values of PCO2 and PO2. But the lower you get with those values, the more life-threatening it becomes. So those are your general concepts to apply to everything throughout the rest of the unit. So again, probably you're going to focus more on hypoventilation and acute respiratory failure, but everything we talk about from here on out can result in that problem. So the first thing we want to talk about is lung cancer. It is one of the deadliest. Oh, now my English is going, where in a handbasket. Okay, lung cancer is one of the deadliest, or the deadliest cancer in this country. It's the number one cancer killer. 30% of cancer deaths are from lung cancer. Lung cancer takes place anywhere in the epithelium of the respiratory tract. It is more common in men than women, and it does peak between the ages of 60 and 70. The number one cause of lung cancer is cigarette smoking. Non-smokers are also at risk from secondhand smoke. Now you guys as a generation are not getting exposed to as much secondhand smoke as even my generation a few years ago. So hopefully that is decreasing, but you can have lung cancer from secondhand smoke exposure. And the reason why it is so deadly is because in many patients it's about 70% spread at the time of diagnosis. So if it's in an advanced stage, of course, we're going to have a harder time treating it. So you remember that from cancer unit, the higher the stage, as a general rule, the less treatable it is. And the reason for that is because there are very few early signs of lung cancer, and we don't routinely screen for lung cancer, although that's starting to change. So to get into a little more about risk factors for lung cancer, as I said, cigarette smoking is a primary cause. It does have many carcinogens in it, and remember that carcinogens are substances that mutate genes and cause changes that can result in cancerous proliferation. It's especially a risk if someone started smoking before they turned 25, or if they smoked more than one pack per day for at least 20 years, and are older than 50. Another primary risk factor for lung cancer includes asbestos exposure, which is really a risk factor for a particular type of lung cancer called mesothelioma. There's also a familial link, so family history can be a risk factor, and tuberculosis. Previous tuberculosis is a risk factor for lung cancer. Radiation exposure is also a risk factor, COPD, and air pollution. There are four. One, two, three. Yes. There are two categories. That's what I'm thinking. I know that I talked about 4 types of lung cancer, but there are 2 actual main categories. They're your non-small cell and your small cell. The non-small cell we'll talk about first, and then the small cell in the next slide. The non-small cell has a better prognosis, than the small cell cancers. And there are 3 categories of non-small cell cancer, lung cancer. We have our squamous, which tends to occur in the central bronchi. So if you remember the central bronchi, they're the ones that branch right off of the trachea, or the hilum, so in that central area. Because it's in the central area, if it grows, it starts to block off the main airways early, so you start to see earlier symptoms of it. So that's why of them, even though most of them or all of them are diagnosed late, this is probably earlier than the rest. And it does metastasize a little bit later as well, so it may be a little bit more treatable. Adenocarcinoma is the most common type of lung cancer. It's about 35 to 40% of cases. it does tend to take place in the periphery. So the peripheral acinar bronchial alveolar. So remembering the acinar are the alveolar ducts and the alveoli, so way out in the periphery of the lungs. So because of that, this one tends to be detected later because it doesn't have a lot. When you're out and way in those alveoli, and we know we have thousands of alveoli, your body's going to compensate. You're not going to feel short of breath because it's just this one little area. However, as it grows and affects more and more of the lung tissue, that's when you'll start to see symptoms and diagnosis. The problem with this particular type of lung cancer is it is increasing in incidence in women, especially young women. If you guys remember Christopher Reeve, he played Superman in the main movies in the 80s. His wife died at like 41, 42 of this adenocarcinoma. She had never smoked, and she suddenly was diagnosed and died very quickly. So it's very scary, and we're not sure why that this one is starting to increase in incidence. It grows very quickly, it doubles in size in 6 months, and it metastasizes very early. So that's part of the reason for the poor survival rates. Then we have our large cell, which also are quite central, and they tend to distort the trachea. They grow, obviously, as the name implies, they do grow into very large tumors. They double in size in 3 months, so they grow very quickly, and they metastasize quite early as well. And then our last category here, our small cell, have a much worse prognosis than the non-small cell. They do make up a significant portion of lung cancers, not as much as adenocarcinomas, but 15 to 20% of lung cancer cases. We have our OAT cell, which is our main category of small cell lung cancer. This takes place outside of the central bronchi, so in the interstitial tissue of the lungs. They grow very rapidly in clusters and compress the bronchus, which can cause obstruction of the bronchus, which is a problem because remember the bronchi are what branch into the bronchioles and the alveoli. This one grows incredibly fast, doubling in about 30 days and metastasizes very quickly and widely and is often resistant to therapy. So we try to treat it with, chemotherapy, radiation, and it tends to resist that therapy. And if you remember from the endocrine unit, this is a particular type of lung cancer that does often cause ectopic hormone production. So it's often ADH, and there are other hormones that it does produce, but we often see SIADH with OAT cell or small cell cancer. So you'll have to pull that memory forward as to what is SIADH, because you may see maybe a case study or a question that gives you those symptoms and is asking you, what in the world in lung cancer or in pulmonary world would ADH have to do with anything? But again, as we said, sometimes this cancerous tissue secretes ectopic hormones like ADH. The pathogenesis of lung cancer is essentially the pathogenesis of cancer. So to very briefly review, we know we get, carcinogen exposure, a mutation, a genetic mutation of some sort that will cause these malignant changes in the cells, so including things like turning off the tumor suppressive genes, creating oncogenes that causes rapid tissue proliferation and tumor growth. So again, if you don't remember the adaptation or the maladaptation, we can go from metaplasia to carcinoma in situ to a tumor that is invasive into the surrounding tissue, then the lymph, then finally to distant tissues, and can cause death. Showing you an X-ray with a normal lung versus a cancerous tumor on the other lung. And as far as treatment diagnosis, 10 to 15% of cases are asymptomatic. In many of the other cases that do have symptoms, the symptoms are often attributed to something else, such as an acute illness, a respiratory infection, etc. So that's why diagnosis does tend to be late, and treatment, prognosis tends to be poor. The clinical manifestations will, of course, be based on what type of cancer it is, where it's growing, how big it is it impinging on any other tissues that could give us a hint that this isn't normal, and how quickly it metastasizes. Some intrathoracic, meaning within the lung, symptoms include a cough, which is often dry and persistent, changes in breathing, such as dyspnea, shortness of breath, hemoptysis, which is blood in the sputum, chest pain, increased sputum production, hoarseness, recurring upper respiratory infection or pneumonia, and pleural effusion, collection of fluid in the lungs or elsewhere. Remember, we said we can get a pericardial infusion from some cancers, so that could be the case too. Then we have extrathoracic, outside the lungs, including weight loss, anemia, clubbing, which is a change in angle of the nails that indicates chronic hypoxia, and edema. So sometimes these tumors can grow into the vena cava and cause lack of flow through the vena cava. So it can cause edema proximal to the vena cava. And I think I'm going to end there for now, rather than going halfway into another topic. So when we come back on Monday, we'll continue into our obstructive disorders, restrictive disorders, and then infectious disorders. Have a great Thanksgiving. And again, email me with any questions, and I look forward to seeing you guys on Monday.